So, good evening, everybody from Ortho TV, and over to you, Dr. Janki, for further proceedings.
Over to you, sir.
Good evening, everybody. Welcome again to this series of webinars aimed at DNB and orthopedics postgraduate students. The topic for today is clinical examination of the elbow joint, and we have Dr. Rajeev Ranjan, who is one of our consultants at RSH Hospital, who's going to present this topic today. So over to you, Rajeev. Rajeev, where are you?
Yeah.
You need to show yourself and unmute yourself.
Yeah. Am I audible, sir?
Yes.
You are. Go ahead.
Yeah. Thank you, sir. And very good evening to everyone. Myself is Dr. Rajeev Ranjan, and today we are going to discuss the clinical examination of elbow joint. First, coming to a brief introduction to the anatomy of the joint. It's a compound synovial joint formed by the three bones, the humerus proximally and the radius and ulnar distally. The radiohumeral and the radioulnar articulations are pivot joint, and the ulnohumeral articulation is a hinge joint. Ligaments, the lateral collateral and the medial collateral are the main stabilizers of the elbow joint. And one anatomically significant landmark is the Anconius triangle, which is formed by the lateral epicondyle, the radial head, and the olecranon tip. And this signifies a soft spot, which is where you can palpate the effusion. One of the earliest place where you can palpate if there is any effusion of the elbow joint. And if needed, you can also aspirate or inject something in the elbow joint. Muscles, the flexors of the elbow and the extensors of the elbow are there, and the common wrist extensors and flexors are commonly originating from the respectively originating from the lateral epicondyle and the medial epicondyle of the humerus. This slide showing the lateral ligaments of the lateral ligament complex of the elbow joint, which has four components: the accessory lateral collateral ligament, the annular ligament, the lateral radial collateral, and the lateral ulnar collateral ligament. Out of this, the lateral ulnar collateral ligament is the main restraint to the varus force. The medial ligaments are having the three bundles: the anterior, the posterior, and the transverse bundle. And here I am showing the Anconius because it is one of the dynamic stabilizers of the elbow joint, and it serves as a it supports the lateral collateral ligament, and it's commonly seen torn when there is a tear of the lateral collateral ligament complex. Coming to the clinical cases which we used to the DNB or the MS candidates used to get there in Viva exams. So it's the approach is same to any other case. Like first you have to start with the history, and then you have to move on gradually over the inspection, and then palpation, movements, measurements, and finally to the neurological examinations. In the history, first you have to know about the demographic data of the patient, like the name. The importance of name is once you have asked the name of the patient, start calling him or her by the name, then he is more comfortable with you, and he will be more cooperative with you also. And the age is having the significance, as there are prevalence of some disease condition in some particular age group, and also the management varies with the age of the patient. Sex is important. Some conditions are more common in females, and some are more common in males. Marital status is just to know about the support which the patient can get if he is going through some treatment. Occupation is having the significance where whether the patient is having some difficulty in his occupation for which he has come. So you need to know the occupation, whether he is an office worker, he is having a desk job, or he is manual work laborer. You need to know for the planning of your management. Presenting complaints, we will see in the next slide what are the common presenting complaints. And the history of presenting illness, you need to know how the things have started, how they have progressed, whether there is waxing and waning or the gradually the things are becoming more severe. You need to know all the things. Past history, where there is any significant past history pertaining to this particular case, you need to mention that. Treatment history, whether the patient has undergone any treatment and what was the response to that treatment, that also becomes very significant. You need to know that. In case of elbow, the history of massage or manipulation or immobilization becomes significant, but this is one of the joints which is more prone for stiffness. Dominance, it's the upper limb, so we need to know the dominance, whether the patient is right-handed or the left-handed. It also helps in the planning of management in some particular cases. Functional disability, need to know that because which activities the patient is finding any difficulty or he is not able to perform that, that helps in the planning of management also. So the common presentations around the elbow joint are the pain, swelling, deformity, and stiffness. And these are the presentation about you need to know, because these are only the cases which usually comes in the viva, in the practical exams. Instability is one of the cases, but it comes very rarely for postgraduate examination. And neurological symptoms are also not so significant considering the elbow cases in the practical exams. Regarding symptoms, you have to ask about the onset, how it has started, and the course, how it has progressed, whether it has worsened over the period of time or it's of the same intensity or the same severity since the time it has started. Duration, you need to know whether it has started acutely or it's very long term this problem, and whether it is present since birth. You also need to know that whether this the condition or the problem is localized or is generalized, or there is radiation of the problem or the pain is, you have to ask. If there is history of pain, you have to also ask any association with the fever or trauma prior to that, or fever along with pain. Majority of the cases in the exam are of the elbow cases in the exam are painless. If painful, then we have to ask all these things are shown in the slide from the patient, and it's a very common mnemonic which we also used to read during our UG times. It's the Socrates. You need to ask the site of the pain, whether onset of the pain, character, whether it's dull aching or throbbing or stabbing, whether the pain is radiating to any other joint, whether the elbow pain is radiating to the shoulder or the wrist, or whether it is, there is any referred pain also. You need to ask association with any other sign or symptoms, time course, how it's whether any pattern which is variable with the time, whether it did any diurnal variation or it's present throughout the day. You need to ask. And you also have to know about the exacerbating and the relieving factor, whether it is exaggerated by the symptoms or the pain is exaggerated by the activity, or it's present even during the rest. You need to know that. Severity or the intensity of the pain is also having some bearing on the management. So moving to the examination, we have to follow a particular sequence for every cases, almost every cases, considering be it elbow or any other cases in the orthopedics or anywhere. We have to start with the look, then we have to go for the feel, and then move, and then measurements, and if there are any special tests. And the most important thing is at the end you have to look for the distal neurovascular status of the limb. Like we can see the importance of the, in the case of cubitus valgus, because of the non-union of the lateral condyle, the presence of the tardial nerve, we have to look for that. Coming to the inspection, you have to look at the patient from the front, back, and the sides. From the front, you have to look for the alignment, any presence of swelling, wasting, or a scar. In the adjacent picture, we can see there is wasting of the arm of the patient, of the left arm of the patient, and alignment. There is slight varus. Apparently, there is varus of the left elbow. From the back, you have to look for the 3 bony points, presence of any scar or any swelling in the paratracipital regions, or any other swelling present around the elbow joint. From the sides, on the lateral side, you have to look also for the alignment about the where there is any sagittal plane deformity is there or not, where there is an flexion deformity. You have to look for that. And the lateral, and also for the lateral epicondyle and the radial head olecranon, and there is fullness, like in the where we can see on the anconius triangle, there is any wasting or not. From the medial side, examination of the medial side is also very important, because you may miss, if you are in a hurry, then you may miss examining the medial side, and you may miss any surgical scar and the history of any previous surgery. This slide showing the inspection, whether you have to look from the front and from the back and from the sides. The medial side is not shown there, but you have to also look from the medial side. And in this photograph, you can see this patient is having the apparently cubitus varus. I'm saying apparently because I don't know, because this patient is not having the full extension of the elbow. He is apparently having the FFD, that is fixed flexion deformity of the elbow joint. Why I said apparently? Because it may get passively corrected, because I have not examined. We can't say on this photograph whether it is passively corrected or not. So in this photograph, we can see this patient is not able to fully extend his elbow, and the flexion is also limited. It's hardly 100 to 110 degrees flexion on the left side of left elbow. In this young boy, we can see there is, and you have to inspect the best position is the anatomical position. Both the upper limbs should be supinated, and by the side of the body, the position in which you have to inspect the patient. In this photograph, we can see this young boy is having that cubitus varus deformity of the left elbow, and it's also called the gun stock deformity. It's like the loading barrel of the old long barrel guns of the older times. And in this case, we can see there is valgus deformity of the right elbow in this younger. And moving to the palpation, first you have to look for the temperature. Before going for this, remember to warm your hands by rubbing to each other before touching the patient, because if in this winter, if you touch the patient with the cold hands, that part may go into a spasm, and the first patient may not be able to further cooperate with you for the next part of the examination. And in this COVID times, also remember to sanitize your hands before and after touching the patients. Look for the tenderness over the soft tissue points and the bony points. The bony points, like the 3 bony points, and the lateral epicondyle, the medial epicondyle of the humerus, the olecranon, and the radial head. Palpate any swelling. If any swelling is present, palpate for the ulnar behind the posterior medial epicondyle. Look for any snapping of the ulnar nerve. Lymph nodes, you should look for the epitrochlear lymph nodes around 1.1 centimeter proximal to the medial epicondyle. If they are present, you have to mention, and you have to look from on the both sides. Whether this inspection or the palpation, you have to do it bilaterally on the both upper limbs. You have to do it to compare the changes. How to palpate the bony landmarks? The important landmark, the lateral epicondyle, you have to start from the lateral supracondylar ridge, go distally. The most distal and the lateral part, lateralmost part is the lateral epicondyle. Similarly, on the medial side, start with the medial supracondylar ridge of the distal part of the humerus, and then most medial and the most distal part prominence is the medial epicondyle of the humerus. For palpation of the radial head, you have to go from the palpating the lateral condyle and then go distally. Then there is a fossa. And after that fossa, you feel a hard structure, which is the radial head, and it is conformed by pronating and supinating the forearm. Olecranon. For palpation of the olecranon tip, you have to start from the subcutaneous border of the ulna distally and then move gradually move proximally up to the point where there is the shin is ending. That is the olecranon tip. Three bony point relationship. During palpation, you have to palpate the three bony point relationship. You have to mark it. And you have to draw a triangle, which is in majority of the books say this is the isosceles triangle with the elbow flexed at the 90-degree. This is the in this the photograph. This is the lateral epicondyle, the marking of the lateral epicondyle. This is marking of the medial epicondyle and the tip of the olecranon. And this is isosceles triangle at the 90-degree of flexion of the elbow, and in extension of the elbow, these 3 points come in on single horizontal line. This sorry, this photograph on the side, on the lower side, is showing the how to show to examiner. We have to keep your thumb on the medial epicondyle and the index finger on the olecranon tip and the middle finger on the lateral epicondyle. Why this awkward position is shown here? Because you should not be obstructing the view of the examiner while demonstrating these examination points. You have to show it to the examiner, so you may have to acquire this awkward position sometimes. Coming to the movements which we can examine at the elbow joint are the elbow flexion, extension, which happen mainly at the humero-ulnar and the radio-ulnar joints. The humero-ulnar joints, and the supination and pronation at the radio-ulnar and the syndesmotic joints, the elbow flexion and extension. Other than that, we'll see in one of the cases where we have to check for the rotation, and how we will look for that we will see in further slides. So the normal range of the flexion varies slightly. It's around 0 to 150 degree normally, and around 0 to 10 degree of hyperextension is also considered normal. But the functional range of the flexion, it also varies in several books. Majority considers 30 to 130 degree of flexion as functional range of the elbow. To this another movement, the supination and pronation, we measure it from the neutral position, that is the mid-prone position of the forearm. The supination is slightly more than the pronation. It's around 80 to 90 degree of the supination and around 70 to 80 degree of the pronation in majority of the cases. And the functional range of the supination and pronation are the 50 degree each. This younger having the cubitus valgus deformity of the right elbow, we see how we have examined the movements of this girl. It's on the right upper photograph. We can see there is patient cannot fully extend her elbow, and there is around 30 degree of flexion deformity on this side, and the further flexion is up to 90 degree only. So the range of flexion for this patient would be 30 to 90 degree of flexion. And coming to this supination and pronation, on this side we can see that the left upper limb is having the full pronation around 80 degrees, and the right upper limb is having only it's almost having zero pronation, but the supination is full on the affected side and the normal side. We can clearly see here, and it has this photograph also shows the method of examination. You have to ask the patient to tuck his arm over around the body, and then gives commonly the two different color pens in their hands. And best thing is you first demonstrate them then how to perform it, then you ask them to show it to them. And in that case, that is easier to measure the quantify. Also you can also use you should also use the goniometer. Here we can put the goniometer on the dorsal side, one arm on the dorsal side and one arm vertically, and you can measure that angle of the pronation. And in case of supination, put the horizontal arm of the goniometer on the palmar side and one arm on vertically, and you can quantify the angle of the supination also. These photographs show the best method to examine the movement of the elbow joint, because in this method we can compare the bilateral movements simultaneously. In this, the examiner asks the patient to turn away from him and then abduct the shoulder at the 90-degree and then fully extend the elbow. In this photograph, we can see that on the photograph on the right lower side, we can see the person can extend his elbow fully. But on the right, on the left upper photograph, that we can see that the person is not able to fully extend his elbow. But on the normal side, the right side, he can fully extend it. So he can easily compare the movement on the both sides. And on the right upper photograph, we can see that the right upper limb patient can fully flex, but on the left side he cannot fully flex. It's hardly up to the 70-degree of the flexion he can achieve. But on the left lower photograph, left lower photograph, you can see that what is the maximum flexion and you can when we can achieve at the elbow joint. It's fully flexed. The patient can touch his shoulder with the fingers in this position. To quantify the flexion or extension, you should use the goniometer and you should practice it, because once asked in the examination to demonstrate it, if you have not practiced it, then your body language can show to the examiner that you are not accustomed to this procedure, and that will have a negative bearing on your outcome. So better to practice it this using the goniometer. How to use the goniometer? In this, we have aligned the distal part of the distal limb of the goniometer along with the axis of the forearm, and on the proximally along the axis of the arm, and the hinge we have kept at the elbow joint, and then we have measured it. It's around 100-degree of flexion. This is the we have just talked about the movements. So previously in one of the slides we have discussed that rotation you have to measure, because we know that in cases of cubitus varus due to malunited supracondylar fracture, or in some other cases also, there is a rotation of the fragment and the fragment is malunited in some rotation. But it's very difficult to elicit the rotation at the elbow joint. But we can elicit it at the shoulder joint, because the distal part which is rotated, malunited in rotation, is united with the proximal part of the humerus which is continuous with the shoulder joint. So that malunion will manifest at the shoulder joint if it is there. So the center photograph shows the neutral position. We have to in this position to examine the movement, the examiner has to be on the back side of the patient, and he from the back side he rotates the shoulder of the patient. And the center photograph showing the neutral position of the shoulder joint, and this left photograph showing the external rotation. And in case of if the internal rotation is if there is malunion because of internal rotation, so in that cases the external rotation on the affected side will be slightly less, and we can compare with the opposite side elbow shoulder external rotation. And on the right photograph, we can see that we have examined the internal rotation. If there is malunion in internal rotation, in that case, the internal rotation, that elbow will be more internally rotated on the affected side compared to the opposite side. Similar, the rotation you can also check in the prone position of the patient. In prone, you have to ask the patient to adduct and internally rotate the shoulder, and then you lift up the wrist. If you can lift it more compared to the opposite side, then there is internal rotation deformity of that limb. Moving to the measurements, you have to measure that arm length, the forearm length, and quantify a muscle wasting of the arm or the forearm, and the carrying angle you have to measure. For the measurement of the arm length, in this lower table, we can see that the length of the upper limb, for the measurement of the length of the upper limb, the proximal landmark is the angle of acromion, and the distal one is the radial styloid. How to measure, how to localize or palpate the angle of acromion? For that, you have to start from the midline and move laterally to palpate the spine of the scapula, and then you have to gradually move laterally. The point where it turns anteriorly, from the lateral to anteriorly, it moves. That is the angle of the acromion. From there, you have to measure the length of the upper limb if you are measuring it up to the radial styloid, and if you are measuring the length of the arm, then you have to measure from the angle of acromion to the lateral epicondyle of the humerus. And for measuring the forearm, you have to measure from the lateral epicondyle to the radial styloid. And similarly, if you are measuring the length of the forearm separately for the radial and the ulnar column, then for the measurement of the ulnar column, you can measure it from the length of the ulnar column on the medial epicondyle, from the medial epicondyle to the ulnar styloid. It may vary in some of the cases, like in cases of Montesia fracture dislocation, malunited Montesia fracture dislocation, neglected Montesia, you can get the difference in the radial or ulnar column length of the forearm compared to the opposite side. For measurement of the muscle wasting, go for the maximum bulk, where the maximum bulk of the muscle is there, which is usually 7 to 10 centimeter from the epicondyles proximally and distally, and measure the girth of the arm and forearm in that particular point, and compare it with the opposite side at the same point. Carrying angle, we'll see the further slides. Carrying angle, it is the angle of the forearm with the axis of angle between the axis of the forearm with the axis of the arm. It manifests because the trochlea, it extends more distally than the capitulum, creating the carrying angle, which is measured in anatomical position, that is the patient is standing or fully extended elbow and fully supine elbow. We call it, it's normally 5 to 15 degree, 5 to 10 degree in male, and 10 to 15 degree in females. If it is less than 5 to 10 degree, it is cubitus varus, and if it is more than 50 degree, it is cubitus valgus. If the arm is straight, then if we call it cubitus rectus, but technically speaking, this is cubitus varus, because the normal anatomy is the valgus. So whatever is decrease in that valgus angle, we consider it patient is having some varus deformity. Why it's important? Because if we have to go for the correction of that deformity, you have to measure that varus, and you have to add that with the valgus on the normal side. So technically speaking, this cubitus rectus is also cubitus varus, and you have to quantify that accordingly. Special tests all of them are not significant from the examination point of view, but out of that, the varus stress test and the valgus stress test are more important, and the pivot shift and the test for tennis elbow and test for golfer's elbow are more for the theoretical point of view, considering the practical exam. And the most important, like in any orthopedic examination, the joint examination of the joint proximal and joint distal is most indispensable. You can't miss it, you have to do it. So coming to the valgus and varus stress test, you have to hold the arm with one hand and you have to apply, and you have to use that arm as a fulcrum and hold the forearm just proximal to the wrist and apply the valgus force to check the patency of the medial collateral ligaments of the elbow, and it's done at around 20 to 30 degree of flexion with the forearm supinated to disengage the olecranon from the fossa. On the left side, it's shown that how to do the varus stress test similarly, just to check for the lateral collateral ligaments patency. As in a posterolateral rotatory instability, it's not so significant considering the examination, practical examination point of view. But theoretically, you need to know this Horus circle and the point of that radial head, and which part, on which part you can apply the plates or screws, and which part does not articulate with the ulna proximally. You need to know these things. This is a pivot shift test. I'm just skipping it. So for the examination cases of the elbow joint, the commonly cases which come are the cubitus varus, cubitus valgus, neglected dislocation, stiff elbow, and the swelling. Commonly of that is the TV elbow. Cubitus varus. In this photograph, we can see what are the other criteria to quantify cubitus varus. We have already seen to how to measure the carrying angle. Suppose the patient is not having the full extension of the elbow, then still you can say that the affected side forearm is inwardly deviated compared to the arm axis and compared to the other normal side. But I cannot comment whether it's cubitus varus, because the prerequisite for that, which is the complete extension of the elbow, is not possible in this patient. By this way, you can escape and it can save yourself in the examination. Cubitus varus is a static deformity, and for examination findings, you will get the roughening of the both the supracondylar ridges. The bony relationship is maintained, but medially tilted, which we can see that it's medially tilted, so the lateral angulation is there, will be there. So in examination of the, during examination of the patient, you will see that the elbow is marked, the relationship of the three bony point is maintained, but the whole triangle is tilted medially. These are the points which will support your diagnosis. Hello.
Yes, sir. Sir, do you have more slides? It's already 7:35.
I have some more. I will just move faster. Okay. Can I? Yeah. In that, the range of movement of the shoulder, the internal rotation will be increased compared to the opposite side. The supination will be increased and the pronation will be decreased. We have seen in some of the photographs previously. But the flexion extension arc will be same, though the patient will be having the some degree of the hyperextension, and there will be a compensatory decrease in the terminal flexion of the affected side. This is the X-ray of the same patient. And what the most important thing, we have done the X-ray simultaneously, done the X-ray of the both lower limbs to compare, because in the pediatric age group, because of the presence of the physis, we always need to compare from the opposite side. Cubitus valgus also, it's a dynamic deformity, because in majority of the cases it keeps on increasing, and there is three bony point asymmetry, and the other things are there, but because of lack of time I cannot go in more details. This is the X-ray of that patient, which is showing the non-inner, the lateral condyle on the right side. Sorry. This patient is having the neglected dislocation of the elbow and having the fixed flexion deformity, and there is tenting of the triceps we can see. And in her, her supracondylar ridges will be normal. The 3 bony point will be definitely distorted because the ulna has migrated proximally, and there will be, because of that, the shortened forearm length will be there. Radiographs, this is the typical AP view of the elbow. We can see the joint line clearly, and this is the more important is to get the lateral view of the elbow joint, where there is overlap of the radius and ulna over radius over the coronoid process, and there is, we can see the capitulum and then this hourglass constriction. These are the important points you have to look for the look in the examination in the X-rays. And the anterior and posterior fat signs. I'm just skipping it. What is the most important in the X-ray of the elbow joint? You have to look for the anterior humeral line, and it should cross the capitulum. If it is not crossing, then something is wrong. Like where you can see that the supracondylar fracture, which is malunited in extension. So the anterior humeral line is not crossing through the capitulum. And in this capitular line, it's the line through the diaphysis of the radius. It should cross the capitulum in all the flexions of the elbow joint. If it is not crossing, then something is wrong, where you can see it's the dislocation of the elbow joint. Pediatric elbow, as I have said, or you have to take elbow X-rays of the both sides to look for the epiphysis, and you need to know if the X-ray is shown in the examination. You need to know about the ossification timing or the ossification of this physis. Bowman's angle, I'm just skipping. It's just the angle between the axis of the humeral shaft and the lateral physial line. It having some significance in predicting that further varus, how much varus could be seen in this patient. For correction of the deformity, we can also measure, which is normally between 60 to 80 degrees. So in short cases, you have to you will be asked what is your diagnosis, and if you give your the first diagnosis, then you will be asked why did you say so. So you have to start from the history. What was the history which is in favor of your diagnosis? What were the inspectory and the palpatory and other examination findings to support your diagnosis? And you have to ready for your further differential diagnosis. And how you will manage, you have to investigate the patient and further planning depending upon the findings in the investigation. Thanks a lot. So I'm done. Slide. Sorry for the slide delay. I took a little more time.
Thanks, Rajeev. Yeah, I know timing is always an issue with when you're starting out, so don't worry. I think it's important to try and stick to time so that there's enough time for the questions. So DNB students, we need you need to ask questions to Rajeev.
Yes, sir. Good evening, sir. Hello.
Yeah. Good evening.
Yeah.
Raju, sir, why history of massage is so important in elbow cases?
Because this joint is particularly prone for development of this myositis ossificans, and one of the most common site is that brachialis. During the trauma around the elbow joint, that usually gets damaged, and if you do the further massage, that makes it prone for hematoma and further development of the myositis ossificans in that region.
Okay.
So, second question. By and large, use heterotopic ossification rather than myositis. Okay.
Yes, sir.
So, newer terminology is myositis ossificans or heterotopic ossification?
Heterotopic ossification.
Okay.
Okay, because it's not an inflammation of the muscle. Okay.
Yes.
Myositis implies that the muscle is inflamed.
Yeah, Gautam, that is not new terminology, but better terminology.
Well, it's quite, it's been a while, but yeah.
Heterotopic ossificans in, okay. And sir, in every elbow cases, rotation of shoulder has to be mentioned.
So it's not heterotopic ossificance, it is heterotopic ossification.
Okay, sir. Okay, sir.
Yeah, Gautam, your
So
next
you're asking
question.
something else, Gautam?
Yes, sir. In every elbow cases, sir, rotation of shoulder should be mentioned.
Yeah.
Rajeev, you have
Depends.
to answer
Yeah,
it.
yeah. It depends whether what is your case. If you think your case is the deformity is because of the malunion around the elbow. I am talking about the elbow joint. So
Yes.
if it's classically the cubitus varus, then you know what are the deformities you get in that. So if it is internal rotation, then in that case you have to measure the shoulder examination. You have to measure the internal rotation of the shoulder. It's I know it's the time is constrained in short cases, but if it is significant, you have to examine the joint proximal and distal. Like suppose there is a case of tuberculosis of the elbow and there is a small swelling around the wrist joint and you haven't examined it, so it will be a negative bearing on your outcome because it's a significant finding and it may affect your further management. So you have to examine the joint proximal and joint distal at least as minimal as possible for making your diagnosis for to favor your diagnosis.
Okay, sir.
And one more thing, I think there is some compensatory increase in internal rotation in case of cubitus varus. So
That was he has
yeah.
asked about the whether he has to measure, because I have already explained that in the slides in the presentation.
So one thing you mentioned initially is that neurological problems in the elbow are not often there as cases, but I think you could get a cubitus valgus with tardy ulnar nerve palsy. So that's definitely a case which might, if there's the pun around in the center, they might put it up. Okay, so there you need to be able to
Yes, sir.
diagnose the ulnar nerve problem as well. Okay.
So in that cubitus valgus because of non-inner lateral condyle. I said isolated neurological cases are very difficult.
True, but
Yes.
yeah, these are neurological. So the patient
Yes,
might
definitely.
only complain of clawing or something like that.
Yes, sir. Sometimes the patient comes with
complaint.
that paresthesia in the little finger.
And next question, Amit.
Sir, Rajeev here, sir. Good evening, sir.
Good evening.
Yeah, Rajeev.
Sir, how much importance of the examining lymph node, sir, and how to examine that lymph node in elbow?
It's not so significant in cases of trauma, but if it's a case of infection, patient is having pain. Majority of the cases are painless, but if it is a painful condition and patient is also having the history of fever, then you should examine the lymph nodes for the affection of
Which group of lymph nodes, sir?
epitrochlear. Commonly, you should examine.
So which conditions do you see that in?
Tuberculosis of the elbow joint or the sequelae of septic arthritis if the patient is having, no, not sequelae, sorry, but any infection, most commonly in the tuberculosis of the elbow joint.
Anything else?
There are subcutaneous nodules in case of rheumatoids. That one is also.
What else?
And any infective pathology may give rise to or any tumor.
Okay, so lymphomas, etc. Yes. What else?
Students elbow.
Amit?
Even leprosy in Hansen's, you can sometimes get, okay. So you can get ulnar nerve thickening as well as nodules in that area, which look like sort of lymph nodes, and you can get an abscess as well in Hansen. So again, that's another neurological case around the elbow that you might get. Okay, but although it's not as common nowadays, but at one time it used to be not so uncommon.
Yes, Amit, you have one question?
Yeah, actually, in cases of supracondylar fractures, we usually see that actually it is written in the book that the triangle, which is the isosceles triangle, is maintained. The from distance from the tip of the medial epicondyle to the olecranon and the distance of the lateral epicondyle to the olecranon is same, but usually we have seen very often that it's not the same. It comes contradictory to what it is written in the literature. It says that the triangle is rotated in the medially rotated in the coronal plane, but it's not actually, it is.
Yeah, so I think you have to look at what you're actually palpating as the most prominent point. Okay, so what happens in cubitus varus?
The axis of the forearm is inwardly deviated as compared to that of the axis of the arm.
No, but what happens in the fracture?
The fracture
Distal
is internally or
fragment.
medially rotated.
That's all. Is it displaced?
Yes, sir.
Is it medially displaced?
Yes, sir.
So what becomes prominent then?
The medial epicondyle.
No, on the lateral side, what becomes prominent?
What else?
It's the
What
end of
else
the
is there?
proximal fragment, okay?
Right, sir.
So once you get callus there, when you're palpating it, you probably feel the end of that fracture more prominent than the actual lateral epicondyle.
Okay, sir.
Okay, so that is why you get this. So this is unfortunately one of these things which get passed down through the ages from examiners to examiners, that the triangle is maintained when you have the fracture. Okay, but that's not the time you can actually palpate it properly. Huh? Okay,
Right,
but
sir.
by the time it comes as a cubitus varus, what you're palpating as the most prominent point laterally may not be the lateral epicondyle, it might be the bump that you're feeling at the end of the proximal fragment.
Okay, sir.
And what to say in examination, sir? Is it
Say
maintained or
what you
not?
feel,
Okay.
say what you see,
Okay.
and explain it to him that you are wrong.
Okay.
Yes. Sumit, you have one question?
Don't say he's wrong, but you might get into trouble. But say,
Yes, sir.
probably because I'm feeling the prominence of the.
Yes.
That's why it looks unequal.
So this stadial palsy means late. How much? How late?
You tell me.
Amit?
Writing.
Minimum 6.
So tell me, Amit, when do you see it?
He's not sure about it.
So it's a very variable time. Okay, you can get them starting as early as 1 or 2 years down the line, and I've even seen them 10 or 12 years, 15 years down the line. Usually they say it takes 6 to 8 years or something like that, but it's very variable.
Yeah. Sumit, you have one question?
Sir, how to differentiate clinically lateral condyle and supracondyle fracture?
So
Acutely. Acutely.
No, clinically, sir.
But in
Clinically.
acute fracture or in a chronic?
Lateral condyle and supracondyle fracture.
In an
It
acute
is
fracture you're talking about.
fresh fracture you are asking about?
In a fresh fracture or in an old fracture?
so for your clinical
Late,
exam, you
sir.
are asking. It is late cases, right?
Late cases, sir.
Yeah.
So
For supracondylar fracture, I have already mentioned that in presentation. What are the findings you will get? First of all, the presentation will be on the inspection. It will be grossly different. In majority of the cases of supracondylar malunion, you get the cubitus varus, and in majority of the cases, why I'm saying majority, because you may get that opposite side, opposite of that. In majority of the lateral condyle non-union, you get the cubitus valgus, and to prove that, or the points to get in the favor of your diagnosis in the supracondylar fracture, the three bony points, it's mostly relationship is maintained in the supracondylar, and both the bony supracondylar ridges are irregular. These are the inspectory and palpatory findings, and the movements. On the movement, you can show that increase in the internal rotation, and there is some degree of hyperextension and the compensatory decrease in the terminal flexion of that affected elbow. These are the findings in favor of the supracondylar one. And but ideally, you should first start with the history. In the supracondylar fracture, the patient develops huge swelling around the elbow. It's not that much in case of lateral condyle. So what I have mentioned, that you, if something is asked like that, you start with the history and then go to the inspection and then palpation and then further findings. In case of lateral condyle, the history will not, the patient will not be having at that the time of trauma, the swelling will not be that much of significance, and the three bony point relation will be altered definitely, and that only supracondylar lateral sided will be only lateral sided. You can palpate the fragment, the movement of the fragment you can elicit, and the valgus you can show, and in majority of the cases of lateral condyle, which is less common in supracondylar fracture.
So, how often can you actually make out a difference in rotation in the shoulder in a supracondylar fracture in a child?
Sir, in cubitus varus, it's we can clearly make out that.
I'm asking you how often have you actually been able to make out a difference in rotation at the shoulder clinically in a child with supracondylar with cubitus varus? Because I can't do it.
So during our easy times, we have done it quite often, and we have got that in.
So we've got a child being operated tomorrow. Show me.
Yes, sir. Tomorrow.
Show me the difference in rotation between the two sides. Convince me that you can tell.
Yes, sir. Tomorrow I will try.
Without twisting the child's arm too much, huh?
And I think one
So
more
it's
thing.
not a very easy sign to pick up, okay? I would not say it's easy. And I think in the very late ones, when they start getting adaptive problems in the shoulder, then you can see it. But in the early ages, it's almost impossible to clinically see a difference in rotation. Okay? And I think the amount of rotation can also vary. It's not every cubitus varus has the same amount of internal rotation.
Yes, that varies case to case.
So,
in every PG teaching course, sir, examiner emphasize on this point, sir.
yeah, but how often can you actually tell that difference?
Yes, sir.
Honestly, I mean, unfortunately, anyway, I would not say about the examiners. It's always easy when you're on the other side of the table, huh?
Yes, sir.
And I think during the examination, it's very confusing to differentiate between these two sometimes. So even after that, when you have made a diagnosis of myelinated supracondylar fracture, and if you are getting an X-ray of lateral condyle non-union, then also don't get deserted. You have to face the viva. So
yeah, so you can occasionally get a varus in a lateral condyle fracture. There are some reasons for it. One is that a malunited supracondylar fracture is one of the predisposing conditions for a lateral condyle fracture. Okay, so some of these children may have had a supracondylar fracture earlier, and then they have a lateral condyle fracture which heals. So actually, they're not getting a cubitus valgus, but it's the varus from the previous injury that you are seeing. Okay, so the other is in the operated cases, you can get a varus. Okay, you can actually get growth disturbance on the lateral side because of the surgery. I mean, you can get growth stimulation on the lateral side because of the surgery, and you can end up with a varus. So we've seen 2 or 3 of those in our own series that they have a varus. But it's unusual. It's
And
mostly valgus. Okay.
sir, even for VIC cases, I think they should look for supracondylar malunion or fracture, because that is also one complication sometimes.
Yeah, so it could be a supracondylar fracture, it could be a lateral condylar fracture, it could be a forearm fracture, it could be a montagia. So it depends. Basically, it's because they get a tight cast put on, or they're not diagnosed in time, that they end up with a VIC. Okay.
Okay. So, any other question you have, Avinash?
Sir,
Yeah.
sir, during clinical examination of elbow, how to demonstrate that actually three bony points are not maintained, the relation is disturbed? How to convince examiner about that?
If it is not bilateral,
First, you have to convince yourself. Only you can convince him. Yeah. So if you can mark out the points and draw the triangle.
Yes.
Okay.
So,
Yes.
sir, we have to flex the elbow, examine in flexion and extension both, so that
Yes.
So flexion is where you see the triangle. Okay.
yes,
Extension, it won't be a triangle. May not be a triangle.
yes, sir.
Yeah. And it is a
you
little
have to compare it
confusing.
from the opposite side. If the opposite side is normal, then you can say that the relationship is altered.
In
Yes.
sir, bilateral cases.
But sir,
Bilateral cases,
like sir, one case you have shown today, sir, the chronic patient of elbow, neglected dislocation of elbow. So she had fixed elbow, so we can't extend that and we can't flex it. So how to?
so in such cases, in any such cases where you cannot fully extend or the fully flex, or you cannot flex up to the 90 degree, then to some extent you can comment upon that in the similar degree of flexion
Oh
or
yeah.
similar degree of extension. I have compared both the sides and I have found this abnormality on the affected side.
Yes, sir.
Sir, for the minimal swelling, where to palpate in the elbow?
He
Like
told
for
you,
the
no?
knee.
I think you're not listening to the
Yeah,
lecture.
maybe.
And conius triangle.
Yes, triangle.
Yeah.
And conius triangle.
Okay. So I think.
So yeah, so I think that's where you'll see the effusion first in the elbow, is that soft spot there.
Yeah. And for the aspiration and all, sir, what is the point from where? From that point,
Sir, and conius triangle.
aspirate.
Yes.
Yeah.
And that was also mentioned.
Yeah, that I probably have made.
Sure.
Okay. You have any questions, Sachin? Yes, Sachin. Okay. So, any other question? The DMBs?
No, sir, all covered.
Janki, what about you? I mean, you haven't asked questions yet. Normally, we have about a dozen from you here.
Janki sir has many questions from you, sir.
The presentation has
Yeah, it's
covered all.
almost everything. Yeah. For the
That's why it was so lengthy.
yeah. Just for the one question, sir, for the tennis elbow, when we are doing the examination, clinical examination, most of the time we have not too many diagnoses for that. When patient present with the pain on the lateral side of the elbow, we just do the the test on the wrist joint and mark it as a tennis elbow. So what all differential diagnoses we should keep in our minds, sir, while doing that? Because that one we most of the common cases what we are facing during the OPD. Cold cases. Any other thing we should keep in our mind if
Rajeev, that's for you.
One of is that radial tunnel syndrome. So I have not covered it too much because it was not important from that examination point of view. So one of that is radial tunnel syndrome, one of the differentials of that. If the point of tenderness is slightly distal, more distal from the lateral epicondyle, then you have to consider that.
What else? So again, you have to look at all the, you can have infection in the elbow. Okay. It could be tuberculosis, it could be any other form of infection involving the lateral side. Okay, so we've seen tuberculosis infection of the elbow being mistaken for tennis elbow initially till it gets worse. You can get tendinitis of other tendons. So you can get a triceps tendinitis. You need to sort of clinically see the difference where the maximum point of tenderness is. Again, tennis elbow, the tenderness is not always very easy to exactly pinpoint. Okay, it varies with people. It could be more towards the extensor mass or on the lateral epicondyle. So the exact point varies a bit. Okay, so you have to keep your mind open for other diagnosis and not automatically jump to tennis elbow every time someone complains of pain on the lateral side of his elbow. You can have gout, or you can have lots of things present, arthritis. Start off with pain on the lateral side.
Sir, one last question, sir.
Yeah,
What
sure.
is Panner's disease?
Osteochondritis of capitulum.
That could be one DD of lateral epicondylitis.
Okay.
Yeah,
So
so
you're
that's absolutely.
Okay, sir.
so I think it's important to take an X-ray, sir, whenever you have doubt or if it is a long-standing pain.
Yeah, I think if the pain persists, you should. And I think, but to actually diagnose lateral epicondylitis or sort of tennis elbow in the true sense, the ultrasound is very helpful. Okay, if you have a good musculoskeletal, that can actually give you the diagnosis. Clinically and radiologically, it's a diagnosis of exclusion, while ultrasound can actually pinpoint it for you.
Yes. Okay, sir. So
Okay.
I think, yeah, thank you so much, sir.
Okay, so thank you, Rajeev. And I think that brings us to the end of this session. And bye till next week. Okay.
Yeah, thank you, sir. Excuse me, sir. So we have a request for you. If it is possible, we can plan a compartment syndrome class by you for the next week, sir.
Who's him? You? Me?
For you, yes, sir.
Okay.
Because
yeah, I thought we discussed that, so we can do that. But although I think most of the people, except for the people who joined recently, would have heard it last year. But I don't mind. I mean, I can do it.
Yeah, because sir, it's a little, it's very confusing, and I think the management is also very important to know for us.
Okay, we can do that.
Thank you so much, sir.
Thank you.
Thank you, sir.